So today, everybody out there may have 100% success with their appliances, and everybody's happy within a week of delivering them. And if that's you, then you probably should just log off now, because I probably see more unsuccess than anybody else out there. We have continual problems, and we've had to learn a lot over the years of how to handle these things. Pretty much every day we get a patient coming in complaining about something, not being able to fix something, and their snoring is still going on, or their TMJ hurts, or they're still fatigued or whatever. So I've put together some thoughts and talked to my team actually about this as well. And I've interviewed them and asked them what are the common problems that you hear from patients, because I don't always hear these things. Sometimes my team fixes these things. So let's just kind of dive in here and talk about some of the things that you probably have seen. So many of you may not have considered this, but at least in my practice, the vast majority of my patients are CPAP intolerant. And it's because the world out there in sleep, they only hear about PAP therapy. In fact, so many patients won't even get a sleep study because they're afraid they're going to have to get a PAP machine. That's the world of sleep. And so most of the time, these patients have failed PAP therapy and they're coming in to see me. So the problem with that is these are already your intolerant type patients. Those patients that are very adaptable, and they'll do everything their doctor says, and they'll just work at it until they're used to it. They'll stick with PAP. But those that are easily irritated, they get off of PAP and then they come to see us. And so they're more likely to be bothered by our appliances than somebody that goes to see CPAP first. So we're already battling that to start with. And I'm afraid many sleep dentists don't consider that and know that we're kind of behind the 8 ball to begin with. One thing that I do suggest is that you certainly find a subset of patients that you would really rather not treat, that maybe you should opt out. Don't think that you have to treat every patient that comes in your door. I'm sure that you don't do that on the dental side. And I would also suggest that you stay away from it on the sleep side. There are just some patients that you can tell, and I'd probably turn away at least a patient a day saying, you know what, you really don't need this therapy. We need to do something different with you. Let me refer you, or let's try something different. This appliance is not going to be effective for you. So I have that discussion fairly often. So let me ask this question. And you said that I can ask questions and people can comment. Okay, so let's ask this. Which of these patients would you rather treat? That female, HI5, got a pretty high ESS, which means Epworth Sleepiness Scale. I'm not sure the knowledge of everybody on this, but that stands for how sleepy the patient is. That's considered to be excessive daytime sleepiness. She doesn't snore that much, but she's certainly fatigued. So would you treat her, or would you rather treat that male with moderate apnea, not that sleepy, but his snoring is bothering his bed partner? Do we have any votes? I can't see anything here on what people are saying, but
we got a male all the way. Male, he'll appreciate it more. The man.
Yeah.
Yep.
Yeah. Of course, everybody is going to say that. If you don't, you haven't been doing this very long, because you're going to know how difficult it is to satisfy this female. Now, yes, she officially has sleep apnea, but what really bothers me are the dentists that will treat this patient and then do a follow-up study. And we'll talk about that a little bit later, but certainly that's not going to do you any good. But yeah, so fatigue is the biggest problem we have in treating. And that's why when I see a patient that comes in and their primary complaint is fatigue, yes, they have apnea. It's usually a milder patient, and it's more than likely a female. Then I hedge my bet every time with that patient. And I say, I give them the whole spiel. There's no way I can promise you that your fatigue and sleepiness is going to get better. we'll do the best we can. And let's talk about some other things that might help in addition to the appliance. Now, what's really fascinating to me is that there's a phenomenon where we see patients who, after treatment and after their apnea is better. So let's say this is somebody with an AHI of 25 and their apnea is controlled, their AHI is now 3, but they're still fatigued, they're still a little bit sleepy. There is a real phenomenon there, and we don't really know why that sleepiness occurs. Over time, it'll get better. And there's just really no answers, but we actually see it in this study 55% of the time, even with CPAP. So if somebody's wearing a CPAP that completely controls their apnea, and we know it's under control, and we know that apnea is the reason for their sleepiness and fatigue, more than half the time, that will remain for a while until they get used to the therapy. And that same kind of thing can happen with appliances. So some causes of this, maybe they've had sleep debt all these years. And I see patients like this regularly. They've been sleepy forever and they're finally getting good sleep, and they're having to make up for it. That's certainly one theory. Sometimes you might consider the fact that now they're feeling really good. They have a lot more energy. They're working out, and then they become fatigued because of that. Sometimes, just like the PAP, we talk about the PAP being a problem with patients, that they can't turn over, and it scoots to the side and leaks and wakes them up, and there's all these problems that can counter the effect that the CPAP is having on them. Same thing can happen with appliances. This massive acrylic or whatever you're using in the mouth, sometimes that can create some problems and maybe a few more little micro arousals because of it. And then maybe they're really craving this good sleep. Now that they've got healthy sleep, they want more of it. So they're just more sleepy. They want to go to sleep because they know it's healthier than it used to be. Most of you probably know there's other reasons for fatigue. The sleep physician in my office, depression is big with her. She always looks at depression at being a reason for fatigue. Some of you may be in this condition, and maybe you've got some depression that's not adequately controlled and you're fatigued and sleepy. That can certainly be one of the reasons. And any of these conditions, we can't rule out anything. So if you've got a patient that has residual fatigue, you've got to look at some other things. Sleep hygiene is very important. We lecture people on this all the time. And then with our HSTs, as you know, most of the time, we're not checking for limb movements. Now, there are one or two out there that will do this. Most of us don't have those kinds of home sleep test units. So we really don't know if they've got periodic limb movement disorder. And certainly chronic fatigue is very difficult to work with. And then another thing is the patient being truthful with you about wearing your device. Now, you may think when you ask the patient, are you wearing this every night? And they say, yes, I'm wearing it every night, doctor, and it's just not working. Are they really? I mean, you can believe them if you want to, and hopefully they're telling you the truth. But when truck drivers will actually wear CPAP while they're driving to get their hours in, we've seen these drivers do it. There's many reports of this happening. Then I just don't have a lot of faith in the truth of these patients out there when they claim that what they paid for isn't working. Just like your Invisalign patients, yeah, I swear, doctor, I'm wearing it 24/7. I never take them out. And yet their teeth aren't moving, and you're going, yeah, okay.
Doc,
Yeah. Yes,
burning question here. So you brought up the residual fatigue from mood disorders like depression.
Right.
That's also, from a medical billing standpoint, it's one of the comorbidities for mild airway issues. How do you determine that? Is there a filter criteria in your visits of what you address first versus after the initial treatment plan? How do you normally handle that?
Well, we talk sleep hygiene at the very beginning, especially if they've got insomnia, if they've got fatigue, sleepiness to start out with. Now, if they're just coming in and they're that guy that's just trying to get their girlfriend happy, that's a whole different story, and we don't go into all that. So we have those as well. But I would say a significant number come in with these complaints ahead of time. So we do talk
Mhm.
sleep hygiene. Uh, Most of them do a pretty good job of it. But
Mhm.
I mean, I'm preaching brown noise and pink noise and all kinds of things for patients to try to get better, deeper sleep. Because
Mhm.
there's some research out now about brown and pink noise, keeping people in deep sleep
Mhm.
longer. I'm always looking at the newest research to pass that on to my patients. But sort of we're hedging our bet there because we're
Yeah.
saying, you know what? We can help you with your airway. If you wear this successfully, we're going to help you with your airway, but we're a team here and you're going to help us help you. You
Yeah.
need to do some things too, because you've told me that you smoke. This is here on your health history. You told me that you only get 5 hours of sleep. I say we can't be there with you to make sure you get your 7.5 hours. That's on you. And
Yeah.
they know it. It's not like they've never
Yeah.
heard that before.
No, I love bringing them into the conversation. That's fantastic. Just because somebody asked a question on the noises, um, what are that's, oh, what's the difference in the colors of noise? If you can elaborate, I know that's a big topic. So a little bit on that and
Yeah.
maybe a recommendation.
Well, I think most people know about white noise and they're used to that. They say, yeah, I use a fan. That's my white noise. But in reality, both brown and pink noise, and they're a little bit different. And I usually tell patients to try both. I always ask them, do you have Alexa? And about 70 to 80% of them say yes. I say, all right, just ask Alexa to play brown noise for you, and they'll do it. Sometimes when you ask Alexa for pink noise, she wants to charge you for it. So you have to kind of be careful about that. But we also have a sheet, and I'm happy to send this to anybody. I've got my email at the end. A
Cool.
sheet explaining the differences between white, pink, and brown noise, and when to use each of them.
Awesome. Yeah. And we'll send an email out with the CEs. We can also send that out as well if you'd like.
Yeah.
Yeah. Cool. Thank you.
All right. Sure. Uh, Obviously, I think probably most people out there are trying to find the most comfortable appliance. In my opinion, they're very close to all being equal as far as effectiveness. Now, there may be some differences depending on, the ability to keep your mouth closed. Sometimes, some of us believe that the 90-degree fins are more effective than the 70-degree just because it doesn't allow the chin to drop back as much. And there's some minor changes like that, but basically most oral devices that bring the mandible forward are equally effective. So the biggest goal here is to create the most comfortable appliance, the one that the patient's going to wear. And the manufacturers that have started using computers to make these appliances, there's several out there. They're trying to make them as small as possible, as discreet as possible, as comfortable as possible. And we're just always on the lookout. If another appliance comes out next week, I'm going to try it. If it looks smaller and more comfortable, I'm going with that. But you don't want the patient, when you insert the appliance, to look like this guy on the left either. It's just something that's that bulky. Most of the time, they're just not going to keep wearing it, especially if they can't even close their lips. Now, the sleep study can also be very revealing. Now, if you aren't looking at a polysomnogram or an HST that looks at periodic limb movements, you won't be able to tell that. But limb movements, as most of you know, can create some micro arousals, some limb movement arousals that will then cause some residual fatigue. Looking at a study that differentiates between apneas and hypopneas, if you see many more apneas than hypopneas, those are harder to take care of. And then sometimes those events are much longer, and most HSTs will not tell you the average length of an event or show you all the different lengths of events. It's impractical. It's a lot of data. There's just no reason to do that other than when we would love to know. As most of you know, an event is an event, whether it's 10 seconds or 30 seconds or 60 seconds. So if you've got some that are longer, then that's a problem. And then just the fragmentation of all of these things combined, because when you look at apneas, hypopneas, RERAs, limb movements, You've got restless legs, obviously, but then spontaneous arousals. All of these things can continue to create fatigue and sleepiness with a patient, even if the AHI is under control. Now, the spontaneous arousal, for those of you that aren't, oh, go ahead.
I'm sorry, man, you're on a roll. And I wanted to pop in. We actually, small plug, we upgraded our interp service this year, and we can get the average length and the longest apnea from just about every device out there. So it's pretty incredible. So that data point you're looking for is available.
That is
There you
very
go.
cool. I'm so glad you brought that up, because that's great information for situations like this.
Yeah.
And
Cool.
patients will, a lot of times they'll ask, why, and actually my team asked me this too. They'll say, their oxygen isn't bad at all, but their AHI is 32. I say, well, those are going to be short events. There's not enough time for the oxygen to desaturate. And then you'll see some that the AHI is 12, and they spend 12 minutes or 12% of the night under 90. So that would help us to have those discussions, obviously.
Yeah. Yep. Cool.
All right, so the spontaneous arousal, there's lots of reasons for these, and these are just sort of like unknowns. Some people just have lighter sleep all night long. Usually it's the guy that says, yeah, my wife, she's such a light sleeper. It's just ridiculous. I don't snore very loud, but she's a light sleeper, and that's why I'm in here. Well, maybe not. But, depression can cause these spontaneous arousals. Anxiety, even other physical health conditions can cause them as well. So I always tell doctors that they really need to be confident in cognitive behavioral therapy for insomnia, CBTI. There's lots of things that go into this. We refer to a psychologist for this. In our area, UT Southwestern Medical Center has a 6-week program where they meet as a group every Saturday. And I'll tell all the patients about this. There's also a CBTI app. So there's lots of help out there for patients if they'll just avail themselves of it. I've kind of divided into 5 categories. There's ingestibles, and you probably know the problem with all of these things. This is nothing new for most of you, but activities, health-related problems, there's the environment, and then there's scheduling. And so if you've gotten good at counseling patients on sleep hygiene and cognitive behavioral therapy, that'll go a long way to help patients appreciate what you're doing. Just today, I had a patient, her AHI was 5, and she was in with her husband, and she's just miserable, can't find any help. I talked her out of an appliance, and I talked all about CBTI and sleep hygiene. And at the end of the appointment, the husband kept shaking my hand. He said, I thank you so much. Nobody else would have done this. And it's just the right thing to do. So I suggest that you all learn, if you don't already know about all these things, bone up on it and become familiar with it enough so that you can certainly answer any questions, but also help people understand why, even though their apnea is controlled, they're not feeling great. Smoking actually can create a sticky airway for patients. So I look for everything I can to put it off on the patient. And I'll say, listen, you smoke, and it looks like you smoke a few packs a day. When you smoke, it creates that sticky airway, and air has a difficult time flowing down your air passage. It's just more difficult. It's going to stop the air. So that would be one way that you could help us help you, is if you just stop smoking. But nicotine withdrawal can also create those arousals during sleep, again, leading to fatigue. Medications, most of you are aware of, many of them depress REM sleep, certainly all the antidepressants, which, it's good. I never tell a patient to stop taking antidepressant just because it removes REM sleep. But when I ask them if they were ever told this, not one patient has ever said, oh yeah, my doctor told me that it could affect my REM sleep. But I also think it's malpractice for physicians, and I think they're getting better at this. From my perspective, I'm hearing better reports from patients I think physicians, primary care and mid-levels are saying to patients, listen, I would love to prescribe you this medication to help you sleep. The problem is you could have some underlying problems. You really should have a sleep study first. Now, I would not have said that 5 years ago, but these days I'm hearing more good reports like that. And I'm not sure why. Maybe the physicians are getting better educated. I don't really know, but it's a good thing to hear. Shift workers. I try to counsel all my patients away from this, but I also tell them that there's a study that shows if you have the same patient that has a sleep study during the day and give them that same study at night, their apnea will be twice as bad during the day. So it's a fascinating study, and it just goes to show it's harder to treat that shift worker than it is somebody who is working the 8 to 5, 9 to 5 jobs. So I know a lot of people, especially our engineer types, they want to treat the sleep study, and that's just not the right thing to do. I try to guide my patients away from the objective numbers as much as I can, because you'll treat a patient and you'll look at this, you'll see them back in the office and they say, listen, I'm feeling great. My headaches are gone. My wife says I'm doing great. I'm not coughing anymore. I'm not gasping. I'm sleeping through the night. I only get up to use the restroom 1 time when I used to do it 4 times. And they'll tell me all these improvements. And then you'll do a study that shows no improvement in the objective numbers. And then the patient automatically says, this appliance isn't working for me. So you have to be really careful about that. And I sort of have a general rule that if the AHI is in single digits, I strongly advise them not to do a follow-up study. I say, you really don't need this. I say, if you're the engineer type and you have to see the numbers, then okay. But honestly, if you start feeling better and your snoring goes away, your apnea is under control. We can assume that you don't really have to have that follow-up study. Now, that may go against the grain of some sleep physicians and maybe some on this call as well. But honestly, that's my philosophy. I've seen too many times where the AHI is 8 and you do a follow-up study and it's 9, even though the patient's feeling better. But those things I was talking about before, the length of events, the oxygen, you have to look at different things. And that's why they're feeling better. Those events have gotten shorter, oxygen's improved, fewer arousals, but the number is still the number. Be careful about treating the sleep study.
I gotta hop in with a couple of loaded questions here on that one.
All right,
So,
I knew.
I got medical background coming from the sleep center days, building those places, working with these sleep docs. You employ one, you work with a bunch. How do you balance that? I'm very aware you said I start with a single digit in the AHI, meaning we're a mild case. You're technically in the success criteria of AHI below 10 for an appliance in the first place. Add some clarity. You've obviously got a reputation for doing great work in your community. How do you talk to doctors about what you just shared here? Like, how do you balance that?
Well, the sleep physician that works in my office, she's perfectly fine with that.
Okay.
Now, I will say, though, that she's much more appliance centric than your average sleep physician, because she's seen the success. She's seen, okay, this can even work with severe patients. And what I learned when I was in medical school and when I did my fellowship in Florida, when I was taught that appliances were the devil and PAP was the only way to go, she said, oh, that's not true. I get that now.
Yeah.
And until sleep physicians see our success, and this is why I tell every dentist that talks to me about this, I say, you've got to report back. You tell your patients to tell that referring doctor and tell their physician, this appliance worked great. And if you've got a severe case that works, we've got, of course, everybody has great stories, but we have some that, AHI 63 down to 2, those kind of things. Physicians need to see that.
Yeah,
But I don't go broadcasting to the other referral sources that I have that's my philosophy.
sure.
I tell you, most of my referral sources now are primary care doctors or mid-levels that don't do the studies themselves. They want us to do the study because we do have a sleep physician in the office. And so they kind of trust that it's all going to be done the right way. And I
Yep.
know most people can't, that's not their reality. So I get that.
Yeah. Yeah, I mean, that's fair. Everybody's going to be at a different spot on their journey. Certainly most are not where you're at in yours. And I mean, out of respect for the whole audience, I want to make sure we get that kind of that full perspective on that. Erin hopped in, her sleep doc said the same thing on mild. You're not doing the follow-up test. You're taking the patient subjective information as gospel. I know you enough to know that you're documenting this incredibly well in your chart. Folks, if you're listening and you don't have an EMR that will document this appropriately for your physician colleagues, please make sure you have that. That's incredibly important. Anyway, I don't want to deter you further. You were on a track.
Well,
I just know we're going to get those questions later, so I figured we'd do it now.
sure. Yeah.
Thank you.
But yeah, that's just a philosophy that I've adapted over the years, that it disappoints so many patients when they don't see the objective numbers get better, even though they feel, with mild, just like you said, with mild apnea, insurance requires them to have some comorbidities. They've got to have other issues. And once you solve those issues, then insurance wouldn't even cover another study because they're mild. I mean, they wouldn't cover an appliance. So, okay, let's move on. So, all right, does anybody know who this is? Anybody respond?
You stumped them, man.
Oh, man. You guys don't know who Cal Ripken is?
I do,
Okay.
but I don't count.
Okay. So this guy won he was an all-star 19 times. He played in 2,632 games in a row without missing one, which broke Joe DiMaggio's record by hundreds. He finally just decided voluntarily to stop the streak. But what can you tell by these two pictures? Can you tell either of those things? Can you tell that he's an amazing player? No, I mean, he's got good form, but that really doesn't tell you much. This is like the sleep study. It's a one-night snapshot of what went on that specific night with the patient. Now, I know some studies do 2-3 nights. I get that, but still they're snapshots at this specific time of their life. Who knows how representative it is? It's the status of sleep as we know it right now. It's what we use. We use that stupid AHI number to diagnose them and to come up with because insurance requires it, right? That AHI is the worst thing they've ever come up with, but they've been saying they're going to change this for 10 or 15 years and nothing has ever happened. So we'll see.
So there's a couple of questions. Can I hop in here with those specifically related to that?
Yep.
I wholeheartedly agree with everything you just said, by the way. 10 to 15 years is a long time to make a statement and not do something about it. But we're still here and dealing with what we got.
Yep.
So Abby asked, what if the AHI decreases, RDI increases? Is that still a success?
Yeah, I think so, because you removed events and you've still got some disruptions in breathing. And so it really depends on how the patient feels. But yeah, if the AHI is lower, RDI is higher, you've gotten the patient better. Yeah. Depending on what the numbers are at that point, but yeah, they're better.
Yeah, absolutely. So completely other side of the pendulum here. Alexander asked, patient's initial AHI was 35, delivered the appliance. Now the patient reports no snoring, wife sleeping next to him again. He feels great. Daytime sleepiness is gone. Everything's rosy. Follow-up study, 3 months later, AHI is still 35. What do you do?
Yeah, that's a tough one. I would then look at the oxygen And then I would tell the patient, and more than likely, the oxygen is going to be much better at that point, and the events are going to be shorter, right? So if your HI was 35, it could have been 35 with the average event 35 seconds. And now the average event is 11 seconds.
Yeah.
So it might not be that much longer, maybe advancing a little bit further before that 35 drops down to 6 or something. But if you can't get it, you can't get it. If it stays 35, it's 35. And then just have an honest conversation with the patient. I know you're feeling better. I know it's next your wife and all this, but the research shows, because of the stupid AHI number we're using, that you're not healthy and this could be damaging to your heart. So we need to speak to your physician again, and maybe you can try CPAP again, just have that conversation.
Yeah. And I guess a follow on to that. So obviously further conversation adjustment on the appliance if possible.
Right.
Beyond that, at what point do you as the doctor say, okay, now it's combination therapy, adjunctive therapy, bring the physician in, and now it's this plus something else? When would you use that as what criteria do you launch into that?
Yeah, well, I don't give up yet, because and that's in some slides coming up. So let me kind of get there, and I think I'll address those things.
Sounds good.
So I mentioned this already. We're talking weight loss too, because 50%, well, it's the number one predictor for apnea is weight gain. So knowing that, we know that if you can get them to lose weight, and the problem is there are some issues with the obese patients, something called tracheal tug, which I learned from John Rimmers many years ago. He described this first. Maybe somebody else made it up, but he certainly gave me some knowledge in this area. It's just that tracheal tug is like Mexican handcuffs, and the airway becomes much thinner when you have a lot of extra weight. And when that happens, again, it's harder to make the air travel down that narrow airway. So there's some issues with obesity, and this is why we do like to treat it. Here are some good studies that show that it can have a significant impact on AHI. Again, we have to use AHI. That's what the research uses. That's what insurance uses. That's what we have to do. So we're using AHI here. AHI going from 55 to 29, 57 to 14. And this is just with weight loss. And we see it with our patients as well. So I think counseling on weight loss, I'll tell you that anecdotally, and this is just a guess, I would say 95% at least of physicians or sleep physicians that you'll see in their report discussed weight loss. They haven't really discussed it. It's boilerplate that they have to put in there just to kind of cover themselves. I really think most of them don't talk weight loss. Now, primary care doctors, yeah, they probably do, but sleep physicians, they have more things to worry about. And so they just don't have time to talk weight loss. Well, we do. We can counsel patients on it. I went as far as bringing in a nurse practitioner. Katie here has spent 7 years in a weight loss clinic. And Dr. Debra, my sleep physician, was struggling with handling all of our patients and meeting them to face-to-face before sleep studies. So she needed some more help. So we found this nurse practitioner that had been teaching weight loss, prescribing meds for weight loss for 7 years. And she was looking for something new. So we brought her on, and she's just been amazing. The problem is we're starting to get overrun with patients wanting in to come and see her. And we're not quite sure what to do. But one thing I did tell her is that she needs to put into her regimen, they can't get treated for weight loss until they first have a sleep study to rule out sleep apnea. So it's sort of a loss leader. We don't make a lot of money on the weight counseling and weight prescriptions, et cetera. But we do have the room now, so once we moved into a new facility, and we're using that. Something for some of you may want to consider. Here's just a really quick story. I'll tell you about, we'll just call her Carol because that's her name. And she came in to see me. She had an AHI of 92, and she couldn't even walk across the room without having to sit down. She was so exhausted, so tired, so fatigued. She just really couldn't function. So, but she was PAP intolerant. She tried. She couldn't do it. So I thought, okay, well, let's see about this. Let's make you an appliance, see how it works. The placebo is amazing because in a week, she said she's feeling much better. And that's impossible, but placebo-wise, she thought she was. My assistant, not knowing any better, said, okay, let's send you home with a sleep study. I want to see how you are. And I think the AHI went down to 89. So obviously she wasn't there yet. Now, fast forward 18 months, this is where she is. Her AHI is now down to 5.1, but it's because she's lost a lot of weight. She realized she started feeling better about herself because she's doing something for herself. She started wearing an appliance for her apnea. She said, you know what? I'm doing this. I'm going to start walking. I'm going to start eating right. This is without any surgery, nothing, no weight loss surgery at all. But she was still using oxygen at night. She really didn't want to stop using oxygen. It was sort of her backup. It was her pillow, her pillow that she had from the time she was 2 years old. It's her safety blanket. It's whatever you want to call it. She loved using the oxygen. So it took me a while, but another 18 months later, she had lost some more weight. And I said, all right, Carol, I think now what you need to do, let's try you without oxygen and set your alarm. At 4 hours later, you can put your oxygen in. And that's what she did. And as you can see, her oxygen never dropped below 90%. Apnea is essentially gone, 0.7 with an RDI of 7. So it's amazing what weight loss will do. Now, did the appliance itself do this? No. Would we have gotten her AHI from 92 to 0.7 with no weight loss? No. It's the combination that makes this all work. So please don't forget about talking to your patient about weight. They've heard it before. They know that they need to lose weight. It's not like you're telling them anything new. So don't be afraid to do that. 170 pounds lost in 3 years. Even her glasses lost weight. See that? All right. There are some studies on this as well. If you don't think that it's really true or this is just anecdotal, no, there's plenty of studies showing. This is impressive, though. This showed that 2 to 4 weeks after bariatric surgery, even before they had lost weight, their sleepiness improved, and they hadn't even had a sleep apnea improvement. Their OSA was still the same. So you never know. Some of this is probably placebo. Again, they're doing things for themselves, but they theorized it could also have something to do with cytokine release. Nasal resistance, I don't spend a lot of time on this because every one of you probably are very well aware of this. I can't tell you much other than to reiterate that the biggest non-responders are those who don't have good nasal airway. And you've got to create those relationships with ENTs, talk about different things that they can do on their own. But certainly nasal resistance is important to clear up. There's NeilMed, Breathe Right strips. There's the company did the original studies with those, so we didn't put a lot of credence in that. But then other studies came out showing that these Breathe Right strips actually work. So I'm suggesting to most of my patients who don't score out well on the rhinometer that we use, I tell them to try Breathe Right strips. That's the easiest. Nose cones is something else that you can use. We carry various types in our office, and I give them the option of internal enlargement or external pulling pressure. There's also something called Vivere. For those of you that aren't familiar with this yet, it's been around maybe a couple of years, but more ENTs are using this now. They can do it in office, actually. It's an in-office 20-minute treatment if they're willing to do that. Now, some ENTs say, nah, I don't want to do that. I want to do it in conjunction with turbinate reduction and nasal deviation, septum fix. So they want to do it all at the same time. They don't really want to do this as a separate procedure, but there are some ENTs that will do this, and it can create a significant improvement in nasal breathing. Again, I'm always looking for other ways for my patients to breathe better through their nose, because the appliance works better when they can breathe through their nose. What about changing the vertical dimension? There's there's quite a bit of research about this, but ultimately, some patients are going to do better with increased vertical and some are not. So you kind of have to figure out who those patients are. There's no way that you can say, well, if 80% of patients do better with increased vertical, I'm just going to always increase the vertical. Or if 80% do better with no vertical, with minimal vertical, well, then I'm never going to create increased vertical. You can't do that. It's an individual case. And I don't think any sleep dentist out there would argue that there can be some variations with different patients with different verticals. So I'm a believer in checking verticals. We use the pharyngometer. I don't know of a better technique than this. I know some people like it. Some people don't want to put the money into this, which is fine. I'm using it as the best vertical guess that I can find. I don't know a better way, but this is the technique that I use. But just at least agree that vertical can make a significant difference in the efficacy of your appliance. So if you didn't use a pharyngometer or some other technique, if the patient hasn't quite, they can't advance further, okay? And you've got a minimum vertical. Well, there are other techniques for increasing the vertical. This is what I used to do. I don't do this anymore, but you can put things, as long as they adhere well, they need to adhere to the appliance. You don't want it coming off and having them swallow them. But use whatever technique you can find to increase the vertical and then retest them. And this is how I became convinced, actually, that vertical can make a big difference. I did a lot of this for a while, and sometimes I saw significant improvements with increased vertical. So give that a shot, give it a try, and see if maybe that could improve your patients that don't improve enough with just the forward movement of their mandible. There's something called rostral fluid shift. Many of you have heard about this as well. It's just when we sit down, most people these days sit down all day and the fluid pools in their calves. When that happens, it stays there. They don't urinate it out. They can't, because it's pooled in the calves. They don't sweat it out. So they end up lying down at night and it runs rostrally towards the neck. And we see an increase in AHI numbers and the disease. So we suggest that you maybe raise the head of the bed. And many patients have already done this. They figured it out. They've actually bought a bed that will lift up. They're sleeping on 2 pillows on purpose because of this. So they've already figured this out largely. We suggest either the GI blocks or the bed wedges, something like that. There's all kinds of ways if you don't want to spend a lot of money on a brand new bed that's kind of like a hospital bed. Compression stocking can also help. I personally wear these things every day. I don't call them compression stockings. I just call them long socks. But I'm a big believer in the fact that, in fact, I stand up all day too. So it's not that I sit down, but I know that it can improve my apnea. I wear an appliance every night, and I want all the help I can get. Positional therapy, you guys know all about this. There's no need for me to go into that, but just so you know, if you don't, there's plenty of research showing that positional therapy can be effective. I know that most of my patients don't want to use positional therapy. I get that, but at least I talk to every patient about this, especially if their AHI is controlled on their side, but not on their back with the appliance. And I'll conclude with a few other therapies. Inspire, you've probably heard of by now. They've done a massive amount of advertising, especially here in the Dallas area. A lot of the beta testing was done in this area. So maybe you aren't hearing it as much in your area as I am in mine. But we've seen some improvements, and some patients go through this. It was first approved in Medicare here in the state of Texas, and then insurance companies have come on and they've started paying for it, $35,000, $40,000. It's amazing to me, but they do have some parameters that have been broadened. Their AHI used to be more constricted, and they've broadened that. But in general, I tell patients, really, you need to fail an oral device and PAP therapy first before you do something like this. But we do refer patients out for this, especially if they're intolerant to PAP and they have TMJ problems, for example, that won't allow them to wear an appliance at all. I say, well, why don't you try this Inspire? And I send them to the ENT. And then there's Excite OSA. This is one of the newest techniques on the market, and we're having some good success with this as well. It's kind of hit or miss. I never really know, but we're always adding things again to try to improve the patient's, like sometimes we have some residual snoring. Their fatigue's gone. They've adjusted the appliance out like farther than I could ever get my jaw, and they're still snoring some. So we say, hey, why don't you try this Excite? Right now, it's a money-back guarantee. Those of you that aren't familiar with it, it's neuromuscular stimulation of the tongue. I tell patients it's like a workout for your tongue. Your tongue is kind of flabby. And the idea behind it is just like you'll tone up your other muscles, you're toning up your tongue so that it doesn't collapse as easily back into your airway. And it's just 20 minutes a day for 42 days. Doesn't take much time and effort. And there's a money-back guarantee. So it's something that we talk about quite a bit. And that is it for me. Do we have any questions?
Yes, quite a few. That was fantastic. Seriously, thank you. So I might be going in reverse order, but Dr. Rashmi, he had a couple of questions, but let's start with the Excite because you just covered that. Can you prescribe that, or is it only prescribed by an MD? And also the cost. Just give us a ballpark for what it costs to patients.
Yeah, we can prescribe it, and it costs the dentist $550, and you can decide whatever you want to charge patients. At first, they were recommending $750, and then $950, and now if it's on your website anywhere, it's supposed to be $1650. You can't advertise anything but $1650. In fact, if you go on their website, it'll say $1650. So when the patient comes to you from their website and you give them a figure less than that, you're a hero.
Yep, they figured it out, because I was talking to somebody at $550 to $750, and that was not going to happen in the market. That's like Blue Cross Blue Shield of Tennessee, that in network, gives you 10% above your lab bill in network. Okay, so another one is oral appliance possible for patients with upper and lower complete dentures?
That's one of the most common questions I get. I'm going to say yes, but I will say most of the time this is with my Medicare patients. You'll see some non-Medicare, but most people with full dentures are Medicare age. And so in my office, it's not going to cost them anything to try. But I will make sure that they're willing to wear them at night and make sure that they wear adhesive. And then I will use a number 6 round burr and go into the papilla area. I get permission from the patient first, but I'll create indentations in the papilla area between premolars and molars so that the appliance can lock into those. That's never a problem. I tell patients you're never going to feel those. No one's going to see them. Doesn't harm the denture, but it works really well in helping that denture lock in, or the appliance lock in. But it can create some sore problems that they didn't have before with the dentures, most likely in the upper canine area. And you just tell the patient, if you have any sore spots in this area, we can relieve on your denture a little bit, make that more comfortable. This is no guarantee that it's going to work, but since it's not going to cost you any money, that's how I word it.
Yeah. Otherwise, at some point, you're talking about implant located dentures and switching that up, and
yep,
that is going to cost them some money.
Yeah.
So, okay. Shift back to the CBT therapy. Couple of questions on that. One is Dr. Rashmi has several patients with that he referred for CBTI. Compliance sucks. So what are your fancy magic wands for getting patients to comply?
Well, first of all, Rashmi is a female, so I want to make sure you.
My apologies.
Yeah, but it's because I know her. Okay.
Oh.
Yeah, CBTI. That's when I give them 3 options. In fact, I have a brochure, and I say, this psychologist, which is my sister, I say she does everything telemed. It's really easy. You don't even have to leave your bedroom. You can talk to her this way. She accepts medical insurance, all that. And then I say, you got the CBTI app on your phone. And of course, you can go to this course that I talked to them about. So I try to get some buy-in, but you can't
Mhm.
force patients. I mean, all we can do is educate them, and they get to make the final decision.
Yeah, got it. Little bit pointed from Martin. I thought you were going to be talking about failures, and your spin is, hey, here's the things that don't work, and then here's what we do. So his question: how do you address patients who've developed open bites in both short-term and long-term use of OAT?
Ah, yes. I let the patient make the decision. I mean, we tell them at the very beginning. I'm assuming we're talking about posterior open bites. I've only had maybe 2 anterior open bite patients, and all depends on the curve of speed. But I'm assuming he's talking about posterior open bite. So yes, I talk to patients and tell them that this is a possibility. I say, we're going to give you 4 different ways to get your bite back in the morning, but I nor any of my team members can be there with you every morning to make sure you get your bite back. So it is up to you to make sure that your teeth are back to home base sometime in the day. If it's not, and we don't see you, we don't hear from you, you have made the decision to allow that to happen. Are you okay with that? And we're pretty strong with that. So I have
Mhm.
never, ever had a patient complain to me, no, with the attitude that it's my fault. Now, they'll come back and they'll say, you know, my assistant will say, hey, Dr. Smith, you need to come in here and see Susan. She's developed an open bite. They don't use those words, but
Right,
you know, she's not really
right.
concerned. She just wants to talk to you about it. You know, that's kind of how it usually goes. And then I'll say, listen, this could be a life-saving therapy that I'm removing from you. I can't tell you to stop wearing this because it could be saving your life or somebody else's. Only
Got
you
it.
can. So you've got to make the decision, is this side effect not worth the benefit that you're getting? And then you make the decision.
Got it. I got a question from the chat. Um, Along the lines of failures, what would you consider a failure?
Well, when the patient isn't happy with any treatment that you provided, and I get those, yep.
Yeah.
And in that case, I say, all right, you know, you told me when you came in that you did not want a PAP or a CPAC, regardless of what happens. You you did not want that. And I
Yeah.
said, are you sure you don't want that? And you said, yes. Well, now will you consider it? I mean, we just try to get them to go back to PAP if they've already tried it, or to try it now if they never tried it. And some
Yeah.
do, some don't, and some refuse, and they just say, listen, I'd just rather die in my sleep than wear that snuffleupagus thing.
Yeah. Yeah. That's going to be the comment. The uneducated, not holistic perspective for
Right.
patients.
Yeah.
Yeah. What do you do if the patient has central sleep apnea rather than OSA? And I would also say, in addition to OSA, maybe the same or different answers.
Yeah. Well, I've actually had sleep physicians refer central apneic patients to me for appliances. There's an excellent article by Eckert on, and again, I can send this to anybody that wants, and I read it about once every year, and it takes about 3 or 4 times through it before you understand it. But it's about the cross-pollination between central and obstructive sleep apnea, and we've seen it time after time. We fix their obstructive sleep apnea, and many of the central events go away. And I think some sleep physicians know this, some don't, but I'm not scared to treat a patient with central apnea.
Yep. I'm so glad you said that. Like I mentioned earlier, we do send out a math email to everybody with the CE link. So if it's easier, we'd be happy to math distribute that to folks in that. To your point, I'm guessing that it's old school versus new school. 15 years ago, central sleep apnea, and 15 to 18 years ago, CSA and OSA were completely different treatment paths. They were using BiPAP STs for that. Now they've
Sure.
got all the different studies, some of which you just mentioned right there. And the newer or more newly educated sleep docs that are better well read in some of the newer studies, they're not basing a lot of those treatment principles off of the old school stuff.
Sure. Yeah, I mean, if they're
Good,
PEP intolerant, or BiPAP intolerant, they're mask intolerant,
right?
then you got to try something. And since we
Yep,
know that we've had some success, I keep doing it.
yep. So, got another question. If the AHI goes down significantly, but the patient is still snoring, what are some treatments to get rid of the snoring? You address that if you want to just recap real quick what your next
Yeah,
one or two go-tos would be.
right. So I talk about positional therapy. I talk about elevating the head of the bed. I talk about Excite OSA. Those are the primary things that I discuss. And lastly, earplugs for the bed partner.
And if they're fancy, they go spend $300 on the, Bose noise making earbuds, to sleep in, just not
Yeah,
on their
yeah.
side.
And
Yeah,
honestly, you turn that brown noise up to max on your Alexa, you can't hear anything else.
fair enough. We still do have several questions, and like I shared with you guys, we will answer those. Dr. Ken, if you would, let's go to the next couple slides. If you guys have been on our webinars before, that we do this at the very end. We always want to serve you all as our community. So one thing we realize is that this population here that's on this webinar is likely not just starting in sleep. You guys are coming here to listen to this guy because he knows what he's talking about on a whole lot of topics. So we're putting the discount $300 off of our clinical course. It's a clinical hands-on virtual course on December 16th with Dr. Mona Patel. If you guys feel like you need any support with getting the step-by-step protocol dialed in between you and your assistant, or working through some of these topics like when the oral appliance doesn't work, what if you get a study back with the AHI that's the same? If you're working through things like that and you need some support with the verbiage, it's a great place to go. Next one.
Yeah, you didn't ask me anything about this, but or to say this, but Mona is awesome. So I just had to throw that in there.
I appreciate that. She does too, I'm sure. Yeah, coming from you, that means a lot, man. Yeah, she is fantastic, and the goal is to overserve you guys during that time. If you have burning questions that we don't answer tonight for some reason, and you want to schedule a call with a coach, we would be more than happy to give you 25 minutes of time and see if there's anything that we can do to help you. We help practices work on their workflow, get their verbiage dialed in, and basically do more work in the practice. We want to see you guys do more great work for your apnea patients in your community. So if there's a way we can do that for you, we'd love to. The last slide, thank you, man. You can use the QR code for either one of those. You'll also get a link in the emails that are sent out. We are just past a couple minutes past the hour. So Brooke, if you want to send that CE link in there. Oh, we got your new book in there too, as promised.
All right.
An hour later. Thank you, Chad or Brooke. Yeah, so if you guys want to buy Dr. Ken Smith's book, it is in the chat with that Amazon link. Otherwise, the discounted course offer, schedule a call and get your CE link is there. And we'll get back to some questions here. All right, so what if instead of full dentures, the patient has removable posterior partials? Since oral appliances primarily have posterior retention, how would you make the appliance for these types of patients? They are Medicare and only Herbst appliances are covered by their insurance. What would you recommend?
Yeah, and this is another common question, even from my team. In fact, today I had this very question, and they sent me a photo from my other location of the patient's dentition. Thankfully, they had gotten a scan all the way back. Now, with the Herbst, yeah, I get that, but you've got to have, it's more important actually have teeth in the posterior because of the way the hinges are in the upper. So on the lower, if you can rest the appliance on the tissue, and that works fine, but it also depends on exactly how many teeth they have. If they've still got premolars, but just no molars, this is still effective. We can still make this work.
Awesome. Okay, what about low-level therapy as an adjunct? The research on that. Low-level therapy. You know what, MJ, if you want to respond in there, I'll go ahead and ask the question again if we can get some more details on that. I'll move on to the next one. Abby, you got, do you recommend yearly follow-up HSTs after AHI is treated, or just annual checkups based on the patient's subjective symptoms?
Yeah, we see patients after they've been effectively treated. We see them 6 months later and then yearly after that. And of course, many times they fall off and they just say, you know what, I'm doing great, I don't need to come back in. The people that are most likely to fail their appointments are our follow-up patients, because they're doing fine and they just don't see the need. So that's unfortunate. But yeah, it really depends on what their AHI was to begin with and what their oxygen level was like to begin with. But yeah, if it's like a patient that had an HI of 32 and you got them down to 7 and they're feeling great, then things happen in life. They gain weight, they start taking medications, they're drinking more. I mean, doesn't everybody drink more as they get older? No, I don't know that, but things obviously change. So we go by symptoms, yes. So if they come back in and say, I'm doing great, my bite changed a little bit, but I don't care, then, we might not. But I like to do that follow-up study for sure, because we like to report back to the referring physician that they're still being adequately treated.
Got it. Awesome. Scott asked if we can post the CE link again, team. If you can just copy and paste that in there. Looks like somebody missed it. That'd be awesome in the chat. Thanks, Scott. Amanda asked, what are the 4 ways for patients to get their bite back?
Okay, so there's the AM aligner, which we will make for them. We'll make them, you've probably seen the pads.
Yeah.
We have chewing gum. And I ask patients, do you take a shower in the morning? If you do, and about 80% of the population takes a shower in the morning. So if you do that, put a stick of gum in your mouth, start chewing that, let the hot water beat on the muscles while you're taking a shower. By the time you get out, you could be good to go. Then there's the thinking position where you hold this under your chin and you lean on it. We tell them to do that. And then there's the bite tabs that we use as well. So these are, horizontal strips of plastic, basically. I think we get them Great Lake. I don't remember where we get them. Keystone, I think. And then we just cut strips and we give them that as well, just in case they lose their AM aligner. We had a one today. This stuff happens all the time. The dog ate the AM aligner, so he was coming back in for another one. So the bite tabs, they can use that as a replacement for that.
Got it. Awesome. What do you think about night lace therapy, or let's just say not specifically the night lace, unless you have an opinion on that one, any laser treatment as an adjunct therapy?
Okay, I thought that might be what they meant by low level, that they're talking about the lasers. So
yeah.
I personally have never tried one. I know quite a few dentists that have, and with some success, but I can't really speak well on that because I just don't have the experience. Sorry.
Got it. Initial HST with WatchPat from referring doc, then we use a night owl for follow-up and titration. Is this apples to apples or apples to oranges? How do you know if you're on the right path?
Yeah, I think that's apples to oranges. Yes. I know it's cheaper to use a night lace. I get that. I just like that positional component of the WatchPat. That's just by far our favorite, and it's our sleep physician's favorite as well. And we get a lot of WatchPat referrals coming in to us. That's what we see. So I just always like apple to apples.
Yeah, got it. And anonymous, what's being lasered? The soft palate. That's what they were talking about. Yeah. Awesome. Okay. Have you ever heard of this or recommended making the tight appliances, specifically, like let's say the ProSomnus Evo that comes in very exact from the scan? Do you ever make it in a more passive fit, or do you order it? No, I know there's a loose setting. I think that's what they're trying to ask.
Yeah.
You want to speak on that?
Yeah. I think if you've done, 5 of them, for example, and they're all tight and you have to adjust them, then all you have to do is tell them, we need to dial the tightness down. I mean, they use computers to do it. It is really easy for them to back off on the tightness of those. So it's just a simple request. We had that to begin with. I mean, my first Evo was way too tight, and I told them this is not going to work on me.
Yeah.
Right.
Yeah.
And they redid it. And I said, nope, still too tight. And finally, the third one, just right. And I said, okay, this is how I want them. This bed feels perfect. This is how I
Goldilocks.
right, yeah, to
Yeah.
feel on all of my patients. It needs to be a little more passive than what you've got it. But we had a patient today, he's out on upper 10, and every time he uses one, after a while, it gets loose. So you deal with that sometimes too, because they do get loose over time.
Yep. Yep, absolutely. There's one I'm gonna take here, if that's all right, as a sleep tech. Is there a test well, let's do it together. Is there a test recommendation that aren't as expensive as the watch pad? I'll say it this way, guys. The watch pad is the Ferrari. You don't complain about the oil change when you buy the Ferrari. It's got all the channels, it's got all the whiz bangs, and it's outstanding data. Based on what Dr. Smith said, I'll answer, at least from our end. We have another unit that has positional and it has lower disposable costs. It's really a question of what channels you want to get. So if you're looking for very specific things that are related to WatchPat, i.e. like a Ferrari, then you're going to want to purchase that. It's a fantastic unit, but there are other cost efficient alternatives out there that are not as expensive if you don't need that same footprint in those same channels. The other one that I was mentioning is the Philips Alice Night one. So similar footprint, but it has the positional data with the average apnea length, the longest apnea length. And it does have the positional as well. And we get sleep, wake, and yeah, it's pretty awesome. So Thomas asked, what about high-res pulse oximeter devices like the SAT screen? Want to weigh in on that?
I mean, I think it's okay for screening. And if you want to follow, if your patient has their only problem is oxygen, or that is their biggest problem, I think using high-res pulse ox is good. I wouldn't suggest using it for diagnostic purposes. I mean, because you can't. Insurance won't allow that. Sorry. But we see many patients with, we described before, you know, their nadir is 88 and their HI is 42.
Yep. Man, we're getting a lot of questions on the HST stuff. I think we opened a can here. Your opinion on the Z Machine HST by General Sleep?
I have not used it, so I can't comment.
Cool. Fernando, does Awaken to Sleep sell the Night Owl? We do not retail the Night Owl. We're not authorized resellers of that. We can interpret studies for Night Owl. So we have panel of sleep docs. If you need that support in your state, you don't have a local doctor, we can do that for you. We answer the HRPL one. If teeth are lingually tipped, what appliance is best to fit into undercuts and will come out without too much trouble?
Yeah, if they're lingually tipped, you don't see too many patients like this, but the lingualist appliances are going to be the best for those. They can just barely overlap the lingual and still get good retention and not worry about not being able to get it out of their patient's mouth.
Yep. Two more. Man, you are a rock star. 17 after, we're going strong. All right, Stan asked this. He's 75. He's getting spaces opening in the molars, premolars, using a dorsal from Keller and an AM aligner. There is a distal wrap on second molars. Any ideas what to do? He's thinking about using an ortho chain to close the spaces.
Boy, yeah, he answered my question that the distal wrap wasn't there. I mean, nobody was doing, well, I'm not going to say it, never mind. I don't want to go there. Distal wrapping is huge, very important. I don't know how you're getting spaces opening up if you've got distal wrap and it's intimately done. Now, I haven't done any appliances from Keller. I don't know how loose those are. Is that got a flex lining, or is it got, does it have ball clasp? Let me ask that. So, because if it does, that can open up contacts.
Stan, if you're still on and you want to answer that, we'd love to get back to you. So hit us up in the Q&A for an answer to Dr. Smith's question. We'll move to Roy. Is there a way to get the bite back after it's changed?
It really depends on how long if there's been a disc retrieval, no, and it wouldn't make sense to. But in general, if it's just muscles that are shortening, you can do it. I've had mixed success with it, and largely it depends on how long that bite's been that way. And I tell patients, if you come back, if you decide in the first couple of months that you get this bite change and you'd rather stop using the appliance, it'll probably go back. But I say, if you come back in 2 years and it's been changed for a couple of years, it's not going back without orthodontics.
Yep.
And even then, it's questionable.
Yeah, not if they've had condylar remodeling.
Right.
So Stan did get back to us. No ball clasps, all acrylic.
All acrylic. Man, I wonder if the embrasure, and that's a problem with some scanners, they extrapolate and the embrasure areas are going to be putting pressure in between the teeth, which theoretically could open it. But man, it's pretty unusual for a 100% acrylic appliance, unless that's the case, for space to open up. There's just nowhere for teeth to go. I mean, it's a retain. So I'm a little puzzled right now.
So Stan, if you want to email Dr. Smith at info@sleepdallas.com, Doc, what would you recommend if he did something else?
Well,
like tried a different appliance, maybe? What would you recommend?
Well, I think sometimes also, that speaking to that acrylic going into the brazier areas, sometimes that'll compress the gum tissue and they'll start collecting food in the embrasure area and not occlusally. So that would be another question I have. But if he's talking about just wide open spaces with floss, for example, like there's no more snap, then yeah, I'd love to. Maybe I do know that sometimes clenchers can somehow do this, and it's still amazing to me when you've got the teeth retained by acrylic. I mean, it's a great retainer. So to be opening up spaces, it would almost have to be a clencher. But again, I haven't seen the case or the before and after, so it's hard for me to judge.
Got it. Dr. Rashmi said clencher with interproximal acrylic will do it for sure. Adjust the acrylic. All right. You made it. We had a lot of questions. You all, yeah, it's good, man. It's good. So to you all in the audience, so many of you have stayed 20 minutes over. We appreciate you. Thank you for giving us your time and hanging out tonight. Doc, thank you as well for your time and all the pearls. Any parting words for these guys as they get out there and do more work?
Basically, guys, don't give up. I know this isn't a slam dunk field, but it is so rewarding. And I don't want failures to get you down, because everybody has failures, everybody. And physicians have it, everybody has failures, and just know it's just part of it. And I know many dentists they're a little anal. They're a little like, everything's got to be perfect. I got to get the HI down to 0 or it's a failure. No, it's not.
Yeah, it's
Hang in there, guys.
Yep. And thank you all. We appreciate you. Hope you have a great night. We'll see you next time.
Thanks, Michael.
Yep. Thank you.